live on Wednesday evening, anticipating our members to join, and of course, our experts, Ritu ma'am and Dr. Sujanya, to get connected on the Instagram as we welcome them on the screen. For the today's evening webinar, the first one is the lateral ankle sprains. Yes. So today's first is Dr. Sujanya. Yes, Dr. Sujanya.
Hello, good evening, sir. How are you?
Perfect evening. Oh, Ritu ma'am called me, so I got up. Madam is yet to be.
Yeah, she's joined.
Yeah. Okay. She's yet to see her Instagram.
Good evening, sir.
Yes, Ritu ma'am.
Yes, sir.
Podiatric physical therapist.
Oh my God. Very tough term.
Because your suggestion and the passion, okay, to see that again and again Senthil sir should talk something about pathomechanics, foot and ankle,
Yes,
that
definitely. I want.
make you get interested, okay, to upgrade, again restart wherever you want to build a strong foundation of the body's mechanics from the foot and ankle.
Correct. My foot itself is hurting. I am in sleep. I am taking supination, pronation, inversion, eversion. My foot is paining now because I am full time from last 2 days. I am doing these movements with my foot. So I'm thinking that how the ligament instability in my foot is there, because of that I am feeling the pain when I am supinated my foot. So how my ligaments on lateral side are very weak. So I'm not, I'm getting a little stressed there. So these are the things I am feeling on myself. When I feel on myself, that I am able to correlate that yes, it can be the problem in the patient, that how they feel pain when their foot is in supination or with the lateral ankle sprain or the medial ankle sprain. So this is the way when we feel on ourselves, then it is better understanding according to my understanding. The rest you can tell better.
Yeah, Sujanya will say opposite direction. It's like patient has a suffering, we should feel that suffering, but we should not have the suffering. Okay?
Right.
If we try to have that disorder and we have to feel it, then we can treat them. Correct. But who will treat you?
Yeah, that's right. So I tell my patients very brutally, I'm so sorry. I cannot feel your pain. Nobody else can feel your pain. Only you can feel your pain. So what we will do is go by our functional assessment and see if that improves. Then the brain has no reason to create your pain.
Oh, that is the recent 1 week effect. Mhm. Eh, But see, for example, we see the commonest presentation lateral ankle sprains are. Okay. And most of the times we see that they become chronic and they end up coming as chronic ankle instability. And then in one situation, our own ankles, you might see that we might get a twist, get a very sharp pain, the foot returns, we keep the foot, there is no pain, and we are consciously walking, there is no twist. Sometimes we see that the days when we are exerted too much, we might be walking or standing for long hours. We might get a twist, but the twist is totally painless. There is no ligament injury there. Only the end of the inversion comes. A very sharp pain, if at all it might come, it might come. Otherwise, again we are able to get on with our routine work. So that situation is called as the functional ankle instability, where structurally ligament there is no damage. Sujanya was also highlighting that we'll get functional, but the actual problem itself is functionally the ankle instability is coming and affecting the subject. Structurally there is no damage. Yeah, so it's predominantly it is like proprioceptor deficit, okay, mechanoreceptors desensitized, okay, and they have become totally like sleeping, okay. So the ligament is there just for the kind of anatomically it is there, but it's not doing its functions what is required, okay. Mainly because the ligament has healed in the lengthened position, okay. So because every time we are inverting the foot in the weight bearing, the closed kinematic, or generally joint hypermobility is there, or inadequately initial injury stage, it was not adequately protected when it has to heal. Okay. When we talk of other ligament injuries in the body, especially lower limb, you see none of them happens so easily compared to the lateral ankle sprains. Okay. All other ligaments are like you need some forces. There should be there has to be a sports injury, there has to be an accident. Then only other ligaments of the lower limb will get injured. But if you see this lateral collateral ligament of the ankle or the anterior talofibular ligament, the part, we hardly require any big event. Okay. And as women, we were discussing the foot with relation to the high heels or the body generally hypermobility. Okay, their ligament laxity is more. So ankle sprains are eventually a daily happening. Okay, for women. And many of the times we see that lot of causes happen. Let's listen to the clinical perspective. First, of course, from Ritu ma'am and also Dr. Sujanya. Yes.
Yes, sir. As we notice these symptoms of lateral ankle sprain, normally the patient that on sudden injury or the rolling of the foot on in the supinated position, so that they are having a pain related to the lateral ankle sprain. And because of that, we know that the ligaments which create this problem in the lateral sides, the ligament which attach with the talus to anterior and posterior talus. The ligaments which attach to the fibula, and as well as the calcaneum fibular ligaments. So these three ligaments create a stress. Because of that, the patient feel the pain in their lateral side. But only we cannot assess with this that there is a sometimes not only the articular structure as a ligament instability which we see within the ligament lateral ankle sprain. Sometimes the myofascial component, the muscles which are also in the lateral side, so that muscles are also in the picture which we have to train them. Like the yesterday session itself, you have explained these muscle eccentric and concentric control of these muscle with the Leo and the cut example, that how overactivity and underactivity with the lengthening and shortening the tightness position. So these things are also plays a major role, where the peronei muscles, the longus and the brevis, their tendons are also inserting on the lateral side. So we have to see them also. Maybe they are the cause in the patient, and as well as the neural component, because whenever we see these kind of the situation in AMPT, we always focus on the orthomyoneuromanual therapy, and we train these type of condition with all these structures. Not only the articular, the ligament instability we treat. We see that articular versus myofascial versus the neural component. We keep them in a simultaneous process, and then after that giving them the treatment. After that we work on the functional training, yes, which the sir was saying, that functional ankle instability is always as a recovery part. We have to treat as a instability in the functional part, because structurally there is a no damage now, but we have to give them the functional. So how the proprioceptive training or the functional neurostabilization muscular training is also very important here, which we see, because this kind of injuries we see in the sports people, they are having the injuries. And not only that, some people in the old age, when they are having a problem related to the, they are having a gait related problem, or their balance is not proper. Because of that, when they are on the uneven surface they walking, there's a twist comes in their foot. So these are the things. For that also the balance training is very very important, as a maybe their hip abductors are weak, so we have to see there. Again we move into the laxate approach from the hip, knee and ankle and the foot. So that also plays a very major role when the patient whose gait is affected, whose balance is affected. Then also we have to observe the knee movement also and the hip movement also. So this is the way, as a clinical part, we cannot treat the structure that is only on the lateral side of the ankle. We have to see full picture, how as a clinical view we can treat the patient, so that their balance will be perfect, and their functional activity, or whenever maybe there is a need to change in their footwear, so that is also in the picture that we have to see that. Or maybe they need a neuromanual therapy treatment they want, because the nerve is entrapment is also there. So we have to treat as a neuromanual therapy, because we know that the supination where the plantar flexion inversion is going on. So we have to see that common peroneal nerve. So we have to give them a either need for the slider. So that is also, or with the dorsiflexor reversion with the tibial nerve, also making the balance with the supination to pronation. Or maybe there is the articular part where the higher arch, because of high arch, there is the navicular is also in the high side. So we have to give them a navicular drop. There is a glide to the navicular also to make the balance. So these are the things as a part of clinic we see and we treat according to that. And there are many more functional trainings which we have learned in the functional neurostabilization course there, that how we can train on the uneven surface, on the rough surface, on the soft surface, on the wobble board. So there are different types. Or maybe the pressure biofeedback, by giving them, keeping the pressure biofeedback, we can give them the training to the motor control retraining for the foot also. So that also works in these cases, because I have used it as a for the foot, so that the patient can be in the balance, and the foot inverter and inverter with inverters are in the balance. Or maybe there is a balance training with the glides or the TheraBand, that also give a best way to treat the patient when they are having the lateral ankles. Yes, sir.
Okay. Dr. Sujanya?
Yes, sir. Ritu ma'am has covered most of the arthromyofascial and neural component. There is, in addition to what ma'am has just said, after that thorough assessment where we look at all the kinematics in the neighboring joints as well above, I go a bit further up in the spine as well, because it is everything that you need to see, because if the pelvis is not squared, there's some instability in the not instability, an abnormality in the way the person is moving in the spine as well. My assessment goes a bit further up there as well. And the other thing would be something called dermoneuromodulation is also I do, where working on the sural nerve helps a lot in such cases. The other thing I was mentioning yesterday about, how I would make the person stand with both legs. I guess one leg would be more pronated, the other leg would be more supinated, depending on which foot we are trying to train. So lateral wedging exercises on top of the other four that ma'am has mentioned will also be a part of their recovery process. And there was one more thing I wanted to mention here. Something about yes, posterior tibialis. So training that muscle, eccentric control, and it is very very crucial right from the beginning, and also monitoring the fatigue levels on how much that tendon can cope up during training. It needs to be educated to the patient. Otherwise, sometimes it can if it's overdone, it can cause too much pain in the leg. And again, swelling management is very, very important. So icing the ankle has to be a regular routine in the initial stages because the swelling can block so much of the range. So one thing that they can do free of cost is ice the ankle, and the rest is obviously, as we have mentioned here, that would be something we could do.
Okay. So it thinks between the spectrum of acute ankle instability to recurrent ankle instability to functional ankle instability. And also you see that patients with ankle sprains complaining of localized symptoms, okay, only at the anterior inferior part of the fibula, which is very characteristic of the anterior talofibular ligament. The major pathomechanics is, of course, a plantar flexion inversion. Okay. The same if you do in a neutral inversion, then it becomes the calcaneofibular ligament, the middle one, and the very rare scenario of dorsiflexion and then inversion, then the posterior talofibular ligament. So the three ligaments, okay, like this. This is the kinematics, okay, the three bands of the lateral collateral ligament, how they get injured. But in scenario where the foot is fixed and the tibia and the fibula goes into any abnormal varus, okay, the inversion is created by tibia and fibula. What is happening? Where is the sound coming from?
Sorry, sir.
Okay.
The
No.
dragon.
Yeah. It was looking like Virginia is talking because of the internet. It is not audible.
Oh, no, sorry, sir.
Okay.
I sound like a kid.
Yeah.
Thank you.
See, the only differential diagnosis is between you both. Here, there is nothing that can come. Here, if any kids make sound, means I'll go outside and I'll give properly. Okay. So this inversion, excessive inversion due to the tibia fibula can happen in two methods, or it can injure in two mechanisms. One is the syndesmosis injury. Okay. So the inferior tibial syndesmosis, the joint, so that membranous joint, diastasis, separation, strain, all that. And the other one is lateral malleolus avulsion fracture. Okay. So these two can happen in the closed kinematic chain, and the subject also has the same way weight bearing pain when syndesmosis is injured. Okay. If that is not injured, weight bearing will not be painful, because I don't think lateral collateral ligament comes in the way of weight bearing. It is out of the weight bearing line. Okay, the major thing is the tibia. Very minor is the fibula. Okay, and the next part is associated injuries of lateral ankle sprain is the peronei, the peroneus brevis, which actually comes from the lower part of the fibula. Peroneus longus is from the upper part of the fibula. Okay. They both come behind the lateral malleolus. There is a peroneal retinaculum, and then the brevis gets inserted into the fifth metatarsal base, okay, which is also called as the styloid process. And that avulsion of this styloid process. So this again is a Jones fracture, okay. So you can have lateral malleolus avulsion fracture or fifth metatarsal base avulsion fractures. Syndesmosis injuries. Then the three bands of the lateral collateral. And of course, course, the swelling, whatever we get, if that swelling is kind of responding to this ice cubes massage and everything, you should think that it is only the ligament swelling. But if that swelling is not responding, you should suspect it is associated with the capsule. So capsule injuries, capsular strain also will cause a swelling, which will be like an effusion. That will not go with icing. And then even elevation also will not have a big difference, okay, in the effusion. The next one is you also see, other than the capsular injury, what is the other presentation is the stiffness. In the acute stage itself, the position in which you keep the ankle, after that if you start moving or trying to move, even in open kinematic chain on the bed, okay, you just want to move the foot, it will become stiff, like the positional stiffness, okay. What comes in a degenerative, all this picture, here it will come because of the capsule, the synovial fluid secreted more, okay, as an inflammatory response. That's why it is the effusion comes. So that synovial fluid will become thickened when you are not moving, and when you are starting to move, it will be like very stiff. And amongst all this, of course, the cause, if you want to tell, it is general physiological causes, women, okay, because of the ligament laxity as a risk factor, deconditioning, sedentary lifestyle, poor posture, it's because of the poor proprioceptors. So whole body, the proprioceptive dysfunction happens, okay. So you don't get a proper proprioceptive input in the middle of the range, that is from the muscles, in the end of the range from the ligaments. So if peroneal strain has to happen, that means it is in the middle of a movement. It's not the end range of the movement, because peroneal tendon will not stabilize against in the end range. It can stabilize in the end range if ligament is functional instability, and after that all that is left is the muscles which have to protect. So that situation also peroneal strain can come. So two situations, functional ankle instability, end range means peroneal strain comes, peroneus brevis, and peroneus longus involvement always comes if the great toe, because it is inserted to the great toe, the peroneus longus, so all across till here, okay. So when that comes, and if you want to have a good amount of strain, that means the foot has to be a supinated foot in the forefoot also, okay. The forefoot is from the metatarsal, so the first metatarsal, below that is the peroneus longus, okay, attached. So eventually our understanding has to go like whether the rear foot, this is a disorder of the rear foot, okay, the lateral ankle sprain. Plantar heel pain also, it is disorder of the rear foot, but we saw the contribution of midfoot and the forefoot. So if excessively supinating foot, okay, functionally excessive supination of the foot is happening. Why does it happen? Of course, as Ritu ma'am highlighted, that eccentric contraction of the peroneal, okay, because peroneal keeps the calcaneum aligned. If they are weak eccentrically, in weight bearing, what will happen? It will invert, okay, because their eccentric activity is to what? To control the inversion, okay, when in closed kinematic chain. Another one, what happens is the tibialis posterior, the opposite side, okay, it is supposed to be an antagonist to this, okay, the peroneal, but instead of that, it pulls the tibia, okay, it pulls the tibia, it also creates a varus moment. So tibialis posterior, if you see overactivity and tightness, okay, and in plantar heel pain we saw eccentric underactivity of tibialis posterior being the cause. Here eccentric peroneal is the cause. But what is the adding on culprit to the lateral ankle sprain is a tibialis posterior overactivity at the origin. So that means it is a concentric overactivity. It's not at the insertion. It cannot happen at the insertion because there is weight bearing, and origin only will be influenced. So it pulls the tibia. That creates also inversion. So if I pull the tibia from here, this is weight bearing. I pull the tibia. That also will create an inversion moment, adding on to the peroneal insufficiency. And pain we have seen, of course, local and also the associated structures. Reason for stiffness or reason for effusion, reason for weight bearing pain. A very rare scenario of stair climbing where you are dorsiflexing and you are putting the weight, the posterior tibifibular ligament, okay, there loading, its loading will happen or strain can happen, okay. So dorsiflexion inversion. When you are coming down the stairs, we always have a tendency of keeping it plantar flexed and then the heel will be touching. So that is the scenario where you get an inversion ankle sprain which will affect the anterior talofibular ligament. So mostly you see this mega serials where they show the mother-in-law puts the oil in the stairs and the daughter-in-law will be climbing and coming down having an ankle twist, okay. So these things. And finally you will see the brother-in-law will be doing the foot massage and relationship will develop between Bobby and brother-in-law, okay. So that is the Indian mega serials. So remember about these ankle, mainly what you are requiring is a proprioception, okay. Pain, whether you have to focus, it is only when it is the pain is the constant pain is in the night, okay, very rare night pain, okay. If capsule injuries and of course vascular injuries, very rare, okay, that is also happens in elderly, okay. And then you see for the neural injuries in the vulnerable population, what I tell as vulnerable population, because they have vitamin B12 deficiency. Definitely neural, the connective tissue flexibility or the gliding, the fascia elements between different bundles of the nerve will not be proper. So a tensioning component will always cause an intraneural injury. So the tensioning component of common peroneal is what? Plantar flexion inversion. And you also see that the whole leg goes forward like this, even on a heel strike. Commonly the ankle sprain also happens during the heel strike, normal walking, okay? Because we keep the knee extended, near extension, keep the heel, and then the foot actually, the foot flat happens with the plantar flexion, and the calcaneum also has a gravitational effect of inversion only. We have inversion in the early part of the stance, okay? In the mid stance only it is everting, and then again late stance it is again supinating, okay, calcaneum. So the early part of the stance, high chances that it will be causing again the sprain, okay, because of the inversion. Already that is bound to happen, so it will happen excessively. A plantar heel pain due to plantar fascia pains at the heel of the late stance, and the calcaneal fat pad in the mid stance, okay. So you can think like the early stance is plantar fascia, mid stance is calcaneal fat pad, not early stance, late stance. Late stance is plantar fascia, late plantar L, okay. Mid stance is fat pad, mid pad, okay, something like that. And then the early stance is lateral ankle sprain, okay. So early, late, whatever you want to relate, okay. So that is the mechanics there. So people can either get injured, or when the injury, this will be the most apprehended, okay. There are people who are afraid also that when they keep the foot it will twist, okay. So they consciously overactivate the forefoot. So they will activate the great toe. They want the footwear which has the grips in the toes. Okay. Without that, they won't wear. And if you see, we talked about the pointed footwear. The moment you wear a pointed footwear, definitely it will create a supination effect. So the moment you are getting all this front toes together, okay, the foot cannot pronate, because pronated foot it is the nature of splay foot. It has to spread. Okay. The moment you keep this pointed, all that it can do is supinate. Okay. It becomes rigid. When you keep all the toes together, it becomes rigid. Rigid means supination. It will help for the supination. Okay. And so that is also another reason, the pointed footwear. Other than, of course, heels definitely will cause the twist. We have seen many of the models or celebrities falling down, okay, and their videos go viral, okay. And what we eventually, in a perspective of pathomechanics, yes, of course, multistructural is important, multi-segmental is important. Why is that? Varus moment comes from the tibia, okay. A tibial external rotation in the weight bearing will create a supination. Okay. So that is the Lexit principle. And that tibial external rotation can be eccentric contractivity of medial rotators of the tibia. Okay. So that could be like hamstrings, which is medially there. Iliotibial band tightness. Okay, so it is like the band is actually a fibrous band, but that band at the tensor fasciae lata here anteriorly. So it's an internal rotator of the hip. So that tightness, why it happens is because external rotators of the hip are weak. Abductors, external rotators of the hip. So opposite group gets unopposed shortening, tensor fasciae lata. So with that iliotibial band, overactive or it is short. When it is short, it will create external rotation of the tibia. So external rotation of tibia, again it will cause the supination of the rear foot. So amongst many of the procedures what we do in evaluation, I want to get your focus to what is called as the subtalar neutral. Okay, that means the axis, the bisector of the calcaneum, what angle it forms with the bisector of the leg. Okay, so this angle, how it is between the legs, other side and this side. This angle in non-weight bearing, what is the angle? Okay, rear foot, varus valgus. In non-weight bearing, it is called as rear foot alignment. In the weight bearing, it is called as the calcaneal alignment. So this calcaneal alignment is calcaneo valgus and varus in weight bearing. In non-weight bearing is rear foot varus valgus. What we do is we palpate the two sides, the talus, the talar heads, and then move the calcaneum. Okay, invert and evert. You find a position of the calcaneum where both the sides, the talar head is equally palpable. So that means you are palpating the talar head medially and laterally. Okay. When you invert, laterally it will be palpable. When you evert, medially it is palpable more. When both are evenly palpable, that means you have got the subtalar neutral. That means talus is neutral. So in that position, calcaneum is inverted or everted. Okay, so that is this assessment. So this will guide us to deciding whether we need to mobilize or manipulate the calcaneum. Because if calcaneal alignment is abnormal, whatever we train with the wobble board or neuromuscular training, okay, the body will try to overwork and try to compensate, but It is not the actual the dysfunction that we have treated. Okay, so that is why assessment of subtalar neutral. Many literatures tell like you see the full range of motion, inversion, eversion, full range. You see total range. If it is 30 degrees, give 20 in favor of inversion, and after that 10 degrees it is for the eversion. That middle point is the subtalar neutral. So that is the indirect measure. But palpating the talus, the talar head, and then both sides talus has to be equally prominent, and that time the position of the calcaneum only is the subtalar neutral, because talus is neutral. So this is done in weight bearing also. So if it is weight bearing also, you palpate both the heads of the talus. Both the heads means the medial and lateral part of the head of the talus. Do an inversion eversion, which is by you can move the body into internal external rotation, also tibia. You can move the body by abducting, adducting tibia, okay, by lateral flexions. If you want to rotate the tibia, you can rotate the body, okay, still you can get the neutral. So that neutral position, what is the position of the calcaneum? Behind we have to see in the weight bearing. So that is calcaneum. Also, in that neutral position, what is the position of hip, trunk? Because you will find that the subject rotates, he rotates a little bit to the left, then the neutral is coming on the, if I am rotating to the right, okay. So I am standing, this is my right, okay, the left is the one with the thread. So I am rotating to the right means right foot is supinating. If I am rotating to the left, right foot is pronating, okay. So this is the actual relationship. Some people will have talar neutral when you are palpating the talus. If this is like left side, it is there. I am palpating the talus. I am rotating to the left. After a little bit rotation only, talus becomes neutral. Not when spine is neutral, body is neutral, it is not neutral. Okay. When I rotate to the left only, then it becomes neutral. So it means that the neutral has shifted towards inversion. Why it has shifted? Because of some imbalance from the trunk and the lower limb. So left rotation is producing the neutral. Instead, I should have in the middle neutral. Okay. So then what I should do? I should see other side. Other side when I am palpating, again with the same right rotation, the neutral is coming for right side also. It's not a sprained side, but the neutral is shifted with rotation, excessive rotation to the same side. Ipsilateral rotation is more. Then only the talar neutral is achieved, both the sides. That means the risk factor is more functionally adapted. You don't have to treat that rotation because both sides it is there. But if you see one side is a neutral, one right is neutral, other side left rotation, then only it is coming to neutral. That has to be treated. Same way hip also rotation. Same hip abduction, knee abduction, adduction, the tibia abduction, adduction. Every component what we see, we compare bilateral. How this neutral is getting influenced with various components. In our course, which Ridham was highlighting, the functional neuromuscular stability training, what we actually do is palpate this neutral. If the subject tells left rotation, then it becomes neutral. Okay, left side. Right side is in neutral position itself, it is neutral. Body is neutral, talus also neutral. Then definitely left has to be treated. So that left rotation, we tend to give modifications. We might give a TheraBand to activate right rotators. Because left rotators are overactive, the neutral is shifting towards inversion. Same side rotators, which muscles? It is the internal oblique. Okay, the internal oblique of the abdomen rotates the body to the same side. So internal oblique overactivity, that is producing an inversion moment increased at the ankle on the affected side. If you do not do an assessment, then we might generally give a core stability training, which might help. Okay, it's a non-specific method because internal oblique posterior fibers are part of the core muscles. Okay, everybody will do. And the next one, the external rotation of the hip. So external rotation of the hip also will create a supination effect. Okay, when for example I am standing, I am externally rotating the hip, means it will supinate the foot. Tibia also alone external rotation, if I am doing, it will supinate. Internal rotation of the trunk, same side, external rotation of the hip, external rotation of the tibia, all of them will supinate the ankle. Okay, individual influence. So then hip external rotation, why it is happening? Some people might have a piriformis tightness. Okay, tensor fascial lata tightness, tibia external rotation. Okay, so different structures influence different segments, and then you see for even external rotation of tibia can happen with genu valgum, where medial collateral ligament, because medial collateral ligament, the function is also resisting external rotation of the tibia. Okay, so multiple links you can get, okay, by seeing which all structures externally rotate. Even a popliteus, which is in the knee, is an internal rotator of the tibia. So if that is weak, will it cause external rotation? Okay, we never have imagined, but that will happen in people with knee instability, later developing ankle instability, especially ACL reconstruction. Anterior cruciate ligament also kind of restricts the internal rotation of the tibia, anterior translations, and valgus. Okay, all the three, the anterior cruciate ligament resists. If the reconstructed ligament, sometimes people are very anxious to get recovery fast. So therapist might mobilize the knee joint to get an extra range without doing an internal rotation mobilizations. Okay, we will see that in the knee ligament injuries. But ideally, you see that you need an internal rotation of tibia, then only you will get the knee flexion, then it is physiologically normal. If you have not internally rotated the tibia and you are getting a knee flexion, means knee locked position is extension, flexed is unlocked or unstable, loose packed. So the internal rotation not available. So it will look like external rotation will be more. Okay, even in flexion, because you have not internally rotated and flexed. Okay, it's like rehab associated consequences. So patient with knee ligament injury who is operated will get ankle sprain later, because tibial rotation you did not concentrate during knee mobilization in the post-op recovery phase. When you don't do internal rotation, the tibia remains in external rotation, or tendency to go into external rotation only will be there. Okay, so like this, every mechanism can operate. The easiest shortcut problem solving method what we used in treatment is use of a Mulligan's mobilization belt for the tibia. See that we can internally and externally rotate the tibia easily with the Mulligan belt. We have seen that in the recent demonstrations which we have done. But that is like you keep a patient on the wobble board, the patient tells of ankle pain. Okay, but you need to train the balance. right on day one, you don't have aquatic therapy unit. So the only option is use the tibial rotation MWM and keep the patient on the wobble board. So that proprioceptive training is not compromised because of the pain. Okay. And the other aspect is, of course, the therabands, which we again judiciously use in the functional neuromuscular stability training course, where right from hip or the trunk or the tibial rotation also, theraband can be used. You can easily see that whether internal rotator's activity or external rotator's activity, which one is keeping the patient functionally performing. For example, even balance, unipedal stance. We can never imagine in a routine scenario that patient with an ankle sprain, we just keep them on unipedal stance. But if you are using this judiciously, mobilization belt or the therabands, you will find one position where with one direction of force, that patient will be able to stand unipedal stance for 30 seconds. Then you analyze which is the muscle which I was activating, which is the rotation which I was helping. Okay, this patient, this helps. And then when you do the balance training, definitely it is going to be a therapeutic one, because what doesn't improve the balance on day one is not a treatment at all. And you delay balance training because of other treatment methods. After 2-3 weeks, we train the balance. That is the conventional protocol of rehab. But when you see a functional protocol, we don't bother about the structural injury or the healing. Pain should not be there because subject bothers about the pain. Okay. So we ensure that FNST, that mobilization belt and therabands in various sequence. We might use a theraband for the hip, another theraband for the tibia, mobilization belt differently for the femur, mobilization belt another for the tibia, but still we'll get that day one weight bearing unipedal stance. If it is not a grade 2 or a grade 3 also no problem. Surgeon only will tell that you go ahead, you just train proprioception. That's mostly in elderly where they don't want to do the surgery. Okay. The bathroom slipping, falling, all those things. Okay. And get on with a kind of a perspective where this rotations of the hip, trunk, I'm not talking about sacroiliac or iliacacral, okay, but because that's not the maximum synovial mobile joints anyway. But if you see leg length discrepancy, there are different terms: structural leg length discrepancy, functional leg length discrepancy. In structural leg length discrepancy, we have the true and apparent shortening. True shortening is because of skeletal causes. Apparent shortening is because of the soft tissue causes. Functional leg length discrepancy is hypermobility, overactivity, underactivity. All this causes the leg to rotate abnormally compared to the opposite side, inversion eversion compared to the opposite side. So that creates a shortening and lengthening when we are walking, weight bearing, closed kinematic. So functional leg length discrepancies require functional strengthening of the muscles. It's not like you work out in the gym or you sit in the table and then work out hip muscles. You just strengthen knee muscles, you just strengthen. Okay, open kinematic. No, it has to be in the weight bearing. And the body weight challenge of reaching out, all this. But the rotations have to be concentrated when it comes to the lower limb. So that is where the pathomechanics of a lateral ankle sprain, why it is maintained, why the patient gets it recurrent, okay? Why the proprioceptive deficit is again and again going to that same. Many of the times when we train a proprioception, what we think is we do weight bearing, we keep eyes open, eyes closed, means it's okay, we have trained. But the fact is, how much you are allowing the inversion. You have to train the inversion in weight bearing by 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Close your eyes, bring it back to 6, bring it back to 4, bring it back to 2. The joint repositioning error, okay, in the weight bearing. So that is when actually you are developing the literal, the cognitive or the motor effect of, motor learning effect, okay, of the postural control, okay. So think of various options and see that how pathomechanics can be implicated in diagnosis and how the same could be effectively used in the treatment, okay. And some of the pathomechanical differentiations will involve rear foot stabilization, assess the midfoot, whether it is supinated or pronated, stabilize the midfoot in the subtalar neutral, and then assess the forefoot whether it is supinated or pronated, whether it is abduction, adduction, or inversion, eversion. Everything, the supination side component should be twice than the pronation side component. Then it is normal physiological. If in case you have inversion of 30 and eversion of 10, that means the 2:1 has become 3:1. So this is something which you have to take care. So that means you have to see that the 40 degrees, in that 40, 36 and 13, that also no. Okay, 30 and 10, okay, 25, 15. Or something like that. I'm very weak in the mathematics. Okay, so 26.6 and 13.3. Okay, so if that is to be the actual mathematical neutral. Okay, so again you measure alignments and then you see. There is also another one called as the longitudinal axis of the subtalar joint. So you push, it will invert. Here you push, it will invert. At one point when you push, it will plantar flex. Same way, here inversion, here eversion will happen, okay, laterally. Medially when you push, eversion will happen. In between when you push, dorsiflexion will happen. So that is the longitudinal axis, plantar flexion to dorsiflexion. There is a line that will obliquely come. So you will see whether that line is gone closer to the great toe, away from the great toe, that is the medial shift or the lateral shift of the longitudinal axis of the subtalar joint. And then you see whether you want to give a soft cushion insole, a silicone insole, to ensure that the longitudinal axis which is shifted laterally, can we bring it back to the symmetrical compared to opposite side, physiological symmetry. Okay, so this is footwear related. If the subject tells difference in footwear, different symptoms. Okay, only then. Different surfaces, challenges is usual. Okay, you see that we walk differently in a slippery surface versus uneven surface versus a slope, a down slope. Definitely it's more challenging for a lateral ankle sprain maximum. So see that whether footwear has an effect, and you observe the footwear, whether there is any abnormal wear and tear. Okay, whether medial side more damaged, whether it is lateral side more damaged. That means even a pronation can happen because the subject feels pronation is the only stable position. Because if they go into the supination, so they will keep it pronated, and that is the reason why they develop knee symptoms. Okay, the patellofemoral pain. So because of overcompensation. Okay, so every aspect you can understand the body segments much better as we go deeper. So let's listen to the summary from Sujanya. Yes, what she could integrate and add on. Yes.
Um, so as I started off saying how we can relate different joints above and below, this was much more of in depth of finding out, say for example, the tibial rotation, external rotation, and just not the knee. When it comes to your head, you just jump into the knee, but there are other factors that could be directly and indirectly impacting the knee joint to have the external rotation in the tibia, and how that is impacting the ankle joint instability. So just having a wider approach on the biomechanics and finding out the overactivity and underactivity of all these structures will give us a very clear indication of how far we have to lead the patient into the process of recovery and just not limit ourselves to the localized joint area. So this is a really good and functional neuromuscle stability training is so important. Like when you mentioned about the oblique muscles, a lot of times core component gets missed out when it comes to lower extremity. They just treat this as a very isolated segment away from it's too far. It's like Delhi and Chennai. They don't look at it as
Not like Delhi and Bangalore.
well, too far, too far. That is two different humans, I guess. So somewhere like that, I always learned human body with the map of India. I don't know why, but that's how I used to relate
Like a
things.
mathematician, you are a geographic,
Oh,
Yeah.
yeah. Ask me about geography. I can't tell you which continent, which country is in which continent. I'm really poor at that. So yes, this is a really good way of putting it together. With the rehabilitation when it comes to functional neuromuscular stability, I highly emphasize on that component where anywhere it is functional, assessment has to be functional, the treatment has to be functionally benefiting the patient, and obviously the jargons that we will be using, it's for our thorough assessment and evaluation of exactly where we are targeting to help the patient improve. And yes, I think this is giving us a lot of information on what aspects we have to think about. Over to you, Ritu ma'am.
Yes, ma'am. Very well said. And as the sir has already explained everything, yes, really, in lateral ankle sprain, I will add on that from structure to functional is our goal here as a AMPT part, which we work on the patient-centered approach. So whatever the structure which are as a regional interdependence also influencing, or maybe the compensation is also going on, that is the important part here. So don't think that you are treating a patient with the lateral ankle sprain. You have to check full chain, that is like the leg sit also, that hip knee end, and not now that sir has added how with the body rotation itself we check with the core muscles, or we see that while the ipsilateral movement how the foot is with going to the pronation or the supination. So is there a need of the training of the upper the area where we have to give the training with the TheraBand to train the internal rotators and external rotators, so that can give you a better idea. And the one thing which sir has added, that how to check with the neutral, the subtalar neutral joint, how we keep the check the talar joint. So these things very important when it gives them more idea about that how the valgus and varus of rear foot versus the calcaneal will give us the idea that how the foot is in the movement. Either the inversion is more than the eversion. So these things are also very important, which we never check in these things. We just focus on the structure part basically. But after learning from AMPT, our focus is evaluation through the structural part, then evaluation through the functional part, and then recovery in the functional mode is very important, because foot is a functional joint. We cannot say that it can be, we can keep the foot, even if I am sitting on the bed 100 times, I will do the my foot movement with the plantar flexion, with the inversion. So whatever the movement, sometimes we feel the pain. because like the tibial rotation we do, and sometimes we change the position of our leg also. In that position itself, the foot is moving in the different position. So this is the way we have to see that the joint who needs the movement, so we have to treat them in the functional training. So that is the goal here, which we are learning in AMPT. And these sessions which sir has added on G sir.
The situation where lying down time as a chronic experience, okay, old ankle sprain, and then functional instability is there in the daytime. After activity, then you get a twist, and then you are continuing with the activity, okay. And night time, when you are lying down, after some time again that pain comes, is because muscles are the only structures that are stabilizing. Ligament is absolutely zero, and the muscles are relaxing as you are lying down also. Foot goes inversion, then the pain comes. Okay. So this is like the best aggravated or the worst stage of functional instability. Okay, as we can imagine. Okay,
Yes,
otherwise
so
we are not consciously doing movement or positions. We might just be side lying and the foot may be hanging. But initially muscle is there. After 5-6 minutes, it gets
yeah,
plantar flexion and inversion. Then sharp pain. Okay.
correct.
So
Very
it is
right.
like, so then very soon it will become centralized because it is coming in the rest position. Okay, so it will become central mechanism very easily. Okay, and without a mechanical stimulus itself, pain is starting. Okay, a functional stimulus. So that means it will become not likelihood it will be central sensitization. Okay, faster.
Yes. That's why that we are focusing on the functional recovery. So this is our goal here. And these pathomechanics sessions are, I think it's a very important way to understand the mechanics of any structure, any part, because after attending these sessions, it is very clear that how our brain start working, that we correlate with that. Yes, what are the structure which can be in the underactivity, overactivity, or instability like the ligaments, and how we can reach on that structure by understanding it with their pathomechanics and the biomechanics. So for that, these sessions are very useful. And on the main thing is that you are explaining in the way of the clinical point of view, not any like we are just learning about the anatomy here. We are talking about the clinical view, that how as a clinical features we see in the patient, that is important part here. So that is the thing. So we can correlate that yes, one of my patients, she is having a problem like this. So I can go through this chain from the foot to knee to hip. I can move on, and I can also check the core muscles. So this is the way here we are talking about fully the clinical pathomechanics, which we normally see in daily life. So that is very important. For that, these sessions are very important. So we should not miss this pathomechanics, because pathomechanics is our the first goal of AOMPT. We focus on the pathomechanics, which from very first day I am listening from sir that we have to understand the pathomechanics, we have to understand the pathomechanics. And that's the reason that this year 2023 we are working on this pathomechanics. And after learning from sir, after so many sessions itself, whenever that we are learning, that sir is explaining, again it is opening one more new door to understand one new more thing in every session, which previously I was stuck, or maybe there were confusion, but as per the sessions are going on, so it is clearing our doubt also. So that is the thing, pathomechanics is very important. And as you are adding, and that and we are interacting, so that also gives the best idea to understanding about the pathomechanics. Yes, sir.
Spoiler alert, because I cannot close the session without telling this. Non-weight bearing, we see the alignment, whether it is supinated, pronated, whether midfoot is supinated, pronated, whether forefoot is supinated, pronated. In weight bearing, again we recheck whether rear foot is supinated, pronated, calcaneum, midfoot, then forefoot. And we see pronated in the non-weight bearing stays the same in the weight bearing. that means it is non-compensating. Pronated in the non-weight bearing or supinated in the non-weight bearing becomes pronated in weight bearing. Means it is compensating foot.
Correct.
So whether rear foot alone, mid foot alone, and forefoot alone, you can say whether it is non-compensating or compensating. Because they change in their alignment from non-weight bearing to weight bearing. Many people you will see the arch in a colloquial communication I am talking. Arch will be there in non-weight bearing. When they weight bear, the arch will not be there. It means that it's a compensation. Okay.
Compensation.
Normally that is supposed to happen. So that is non-compensation means arch is there, the same arch stays there. Or arch not there, the same absence of arch continues. So that is non-compensated, uncompensated. Now this comes off another two more probabilities of undercompensation and overcompensation. So that means you are requiring a supinated foot to pronate in weight bearing, but it is pronating only a little bit, not that much what is required. So that becomes undercompensated. Overcompensation is you want the pronation in weight bearing compared to the supination in the non-weight bearing, but it is pronating more than what is required. So that is overcompensation. In a situation where uncompensated or undercompensated, you will correct the foot alignment. I repeat the word, correct the foot alignment with the insoles. Okay, corrective insoles. In a situation of overcompensation or normal compensation, if you are giving an insole, you will just give a supportive insole. You don't have to correct by wedge on the medial lateral, okay, either on the rear foot, mid foot, or the fore. So the implication for orthotics and the pathomechanics, and also understanding the foot in terms of the dynamicity when we are weight bearing means whether the foot is adjusting or not, whether the forefoot is adjusting, mid foot is adjusting, or the rear foot is adjusting. So that also has to be part of our dimension of thinking. Okay. So non-compensated, uncompensated, overcompensated, undercompensated. Okay. It can be supination or pronation in any of the angles. Okay. So it comes both for plantar heel pain also, lateral ankle sprain also. Okay. So that is where the challenge of the foot actually comes. Okay. We have seen the alignment of subtalar neutral. That is the middle stage. Okay. Of beginning of the horror. After that, the compensation, overcompensation, undercompensation, uncompensated. Okay. Normally compensated. So these things are, it will compensate your peace of mind. But ultimately, you will see that it is something which on a routine communication, routine practice, if you are establishing a podiatric clinic or associated with a podiatrist, you will develop that thinking automatically. Okay. Because you will go in depth into that domain. Okay. And to make it simple, definitely our courses are always there. Okay. We have a 3 hours video on lateral ankle sprain where 1 hour of pathomechanics with practical demonstration, pathomechanics for lateral ankle sprain, and 2 hours of manual therapy, lateral ankle sprain, including FNST. Even lunging forward, you do with tibial rotation, with mobilization belt and TheraBand, and then ask the subject to lunge forward. During that also, 1, 2, 3, 4, 5, ask them to come to 3, go to 4, come to 1, go to 5, eyes closed. So it's not just a strengthening. In that itself, we do the repositioning error, like eccentric and control. Okay. So definitely you can explore much more, but it needs dedicated. What I can say is focus. Because in knee problem also you can evaluate the foot. You will modify the foot, the patient will get better recovery. When the knee pain comes after squatting or sit to stand or walking or stair climbing or running, definitely foot will be the major pathomechanical factor in the knee dysfunction. Okay. So, but the only thing is whether knee is primary, so the foot has become abnormal, or the foot is abnormal, so foot is primary abnormal, so the knee symptoms have come. So that is we are doing it with bilateral reference. Same thing, rear foot can go for dysfunction, abnormal position functionally. Because of that, the forefoot can go for malalignment or dysfunctions. Or forefoot is in dysfunction, because of that the rear foot has got the dysfunction. So which is primary? Whether it is the rear foot or the midfoot or the forefoot. The basic assessment, as I have told, that keep this in neutral, see the position of the midfoot. If the midfoot also in neutral, when this is in neutral, one first finding. Next one, see the midfoot neutral, keep it, and then see the rear foot that time. If the rear foot is also in neutral that time, both are normal. Because neutral of rear foot automatically brings the neutral of the midfoot. When you are keeping a neutral of the midfoot, forefoot is supinated. Okay? That means you know that forefoot is abnormal. It's not in neutral. Okay? The position of the forefoot neutral. That is not aligning with the midfoot neutral. So that means you will do afterwards, the forefoot is supinated, for example. So you will pronate the forefoot, you will pronate the forefoot, get the forefoot neutral, okay, and you will find that still the midfoot will be in neutral. That means forefoot is not affecting the midfoot, but the midfoot neutral, forefoot is supinated. You will get an opposite finding. Like A, B, A, B, B, A. A is equal to B, B should be equal to A. If A is causing 2B, then B will not cause A. It will only half of A. Understood? So you will see that the effect that the forefoot produces, you change the forefoot neutral, midfoot will be neutral only. So that means it is not affecting the midfoot. But midfoot neutral creating a supination of the forefoot. That means forefoot dysfunction is the problem and the midfoot is causing that. Okay, or the primary to that. So this is again a description which I have just told you because I have to tell. Without that, closing the webinar, it will be like Senthil sir has not mentioned. I don't think anybody in the world will think about this. But I don't want it to be on records on Instagram or in future in the YouTube anywhere. Okay. So every joint, for example, even in our hand, a distal radioulnar joint is primary, or radiocarpal joint is primary, or midcarpal joint is primary, or carpometacarpal joint is primary. All the 4 joints are in the wrist. You have the problem of flexion extension being restricted. So what do? We stabilize radioulnar and then we see the movement. This is radiocarpal and all other joints are moving. But inferior radioulnar is not moving. We keep one finger at the styloid process, below the styloid process. So the proximal carpal row is stabilized and distal radioulnar joint also stabilized. Now it is midcarpal and carpometacarpal. 2 fingers below the styloid process. Okay. Now only carpometacarpal is moving. Midcarpal not moving, radiocarpal not moving, inferior radioulnar not moving. Okay. So this is like stabilization and we are differentiating. Okay, we are blocking a joint and we are differentiating. In the foot, what I described is You keep a neutral of one joint, check the neutral of the other. Neutral of one, check the neutral of the other. Okay. So this is in neutral, whether this neutral is also actually in neutral. So then it is normal. Reverse direction also is there, means it is normal. The interaction both ways. But one direction it is disturbed, other direction it is normal, means that direction which is disturbed is the primary dysfunction. So that means mid-tarsal will be the primary. It is affecting the forefoot. So think of the muscles attached to the mid-tarsal area, or the joints of the mid-tarsal like cuboid, navicular and cuneiform. Tibialis anterior and posterior, definitely muscles of the mid-tarsal region. Articular, it is the cuboid dysfunction. Many times in lateral ankle sprain, you will see that the cuboid is inferiorly positioned. Okay, inferior. So you do a dorsal thrust manipulation, cuboid manipulation. So that will also help. Okay. So it's all about again what I can say. It's like a adventurous problem solving. Okay, you see that it's a midfoot problem, then you see why the midfoot is supinated. Midfoot is supinated. Okay, so the cuboid has to be plantar. That's why it is supinated. Or navicular has to be dorsal. So it is supinated. Okay, so this was only reason it will cause a midfoot supination. So when it is forefoot, it is the great toe, the first ray. It's plantar flexed first ray. Or you see for hallux varus valgus. Okay, so that is again another reason why forefoot can affect the midfoot and the hind foot. Okay, so we are ready to close the session today, right?
Yes,
And
sir.
see if we can get back for the knee joint, or as per the team members what they say. Okay, right?
Tomorrow.
Yeah. Okay, right?
Because ma'am is also creating, I was thinking about that you should use the taping so that your eyelid will be open.
Oh,
I think,
taping for
yeah,
the
that's a good idea.
taping
Yeah.
for foot and ankle, the pathomechanics you are asking, I thought.
But for here need the taping for ma'am eyes, because sir in one our bell palsy treatment that sir has explained that we can give the taping here na. So the same thing that for you we can use the taping so that your eyelid will be in the open. Ah, exactly. So that will be good for you so that you will not do it like this again and again. There are also extraocular muscles which are in the stress, so you need the therapy for that also.
Hmm.
I
Yes,
will
sir.
take that.
Unipedal stance also you can explore that, looking the eyeballs towards the left versus towards the right. How is your unipedal stance? Okay,
Poor.
only gaze.
Muscles.
If it creates the sway, if that sway increases because of eyeball movement, means read the eye first. Okay, because visual system is an important system in balance. Visual, vestibular, and then the proprioceptive, the somatosensory system comes. Okay, in balance.
Correct.
Right? Although we close the eyes, but still that imbalance in the eyeball between right and left will create a big difference in the unipedal stance disturbance. Okay. Right? So keep your eyeballs safe and sound. Okay. And we can close the session. Okay. Yeah.
Yes, sir.
Okay.
Thank you,
Bye
sir.
Thank you. Thank you. Bye.
bye. We'll meet with the knee joint
Bye.
tomorrow. Okay.
Okay, sir.
Let's get that. Yeah.
Bye, sir. Bye, ma'am.
Bye. Good night.